Good morning for people that are signing on right now. We're still at a few minutes before 8 o'clock. I expect we'll start a minute or so after 8. Thank you so much for joining us this morning for the Cass Institute for Women's Health Grand Rounds. And good morning again to those who have signed on in the past couple minutes. We'll be getting started about a minute or so after 8 o'clock. Thank you so much. It's exactly 8 o'clock now. I'm going to give it just one more minute and then we'll get started. Okay. Well, good morning, everyone. Thank you so much for joining us this morning. I'm Dr. Nina Venkoff, the Medical Director of the Katz Institute for Women's Health and the Division Chief of Breast Imaging at Northwell. Thank you so much for joining us for the Katz Institute for Women's Health Mary and Richard Slone Grand Rounds. Today, I'm pleased to be moderating a conversation with Dr. Gillian Einstein, who I will introduce in a moment. First, I wanted to just talk for a moment about the Katz Institute for Women's Health. As most of you know, our mission at the Katz Institute is to improve the health of women across their lifespan, bridging the gap between wellness and personalized care delivery. We are advancing women's health every day by providing expert coordinated care, educating our community on prevention and well-being, and supporting sex and gender-specific research. Next. These are the pillars of our care and our approach to the way that we are breaking the mold when it comes to women's health. It's focused on 6 foundational elements: reinventing clinical care with our network of experts, continuing medical education as we collaborate with clinical departments, elevating our patient experience, sparking the conversation to improve women's health, community outreach, and our collaboration in medical research and education with the Zucker School of Medicine and the Feinstein Institutes. Next slide. A very special thank you to Mary and Richard Slone for their generous support of this program. The Sloans have been longtime supporters of Northwell and of women's health, and through these grand rounds, we are educating current and future generations of healthcare providers on the latest advances and scientific breakthroughs in the field of women's health. Attendees can receive CME credit for today's grand rounds. Northwell Health is jointly accredited by the ACCME, ACPE, and ANCC to provide continuing education for healthcare professionals. At the end of today's program, we will share a link so that you can complete your evaluation and claim your credit. And as a reminder, you only have 48 hours to claim your credit for today's presentation. The following is Northwell's disclosure policy. Northwell Health adheres to the ACCME standards for integrity and independence in accrediting continuing education. Individuals who are part of this program are requested to disclose financial relationships. All planners and speakers for today's program have nothing to disclose. Please, during today's program, submit your questions in the Q&A feature or in the chat, and we are going to have a moderated panel conversation at the end of the presentation, and I will be relying on those questions, so do please submit them. It is now my extreme pleasure to introduce our speaker, Dr. Gillian Einstein. Dr. Einstein is the Wilfred and Joyce Posluns Chair in Women's Brain Health and Aging, Professor of Psychology at the University of Toronto, and Adjunct Scientist at Baycrest and Women's College Hospitals. She is a board member of the International Gender Medicine Society and past chair of the Canadian Institute of Health's Institute of Gender and Health Advisory Board, and founder and president of the Canadian Organization of Gender and Sex Research. Dr. Einstein leads the Women, Sex, Gender, and Dementia cross-cutting program for the Canadian Consortium on Neurodegeneration and Aging, and co-leads the University of Toronto's Women's Brain Health Rounds. She has published on vision, Alzheimer's disease, pain, sleep, and the effects of estrogen's effects on memory and cognition. Dr. Einstein uses a methodology that she developed called situated neuroscience that employs a combination of qualitative, quantitative, and physiological methods to explore how both sex and gender mediate women's brain health. It is now with great pleasure that I welcome you, Dr. Einstein. The floor is yours.
Thank you so much. I also want to thank you, Dr. Vincent, and also Dr. Rosen for inviting me to speak today. I have very warm memories of Northwell Health and the CAT Center when I came to visit as a member of the leaders group of women's health researchers a number of years ago. So I'm particularly pleased to be presenting for these rounds. You know, menopause, oh, I have to tell you first, let's see. I am not succeeding, Rosanna, in moving these slides. Okay. I have no conflict of interest to report. And the learning goals for today is to learn the importance of differentiating different menopauses, to understand the effects on cognition and brain of estradiol loss and therapy after surgical menopause, and to gain a deeper understanding of patient struggles after surgical menopause. The plan is first to talk about menopause and then the many menopauses, surgical menopause, decrements in behavior and brain in young women with surgical menopause or BSO, how women experience these decrements, and then sum up a bit. So menopause is really having its moment. And I hope to convince you today that this term that we use, menopause, actually covers many different phenomena that can start as early as somebody's teens and can extend into the late 50s. It's not all the spontaneous menopause that we think of that begins at age roughly 51. So I hope to convince you today that not all menopauses are created equal. and that we begin to, for the health of patients and their treatments, we begin to see them as quite differentiated phenomena. So menopause in general is a massive period of transition for many women. They have increased sleep complaints, hot flashes, vaginal dryness, urinary incontinence, and sexual difficulties, and an increased risk of heart disease, stroke, and osteoporosis. And this is generally what we know when we study the menopause that occurs at the average age of 51. It's much studied as a turning point as well for women's cognition on the road to dementia, and speed of research in that area is picking up incredibly. I can assure you there will be many, many talks on this at the Alzheimer's Association meeting in July. But NAMS and the Endocrine Society, as far back as I think it was 2014 or 2015, published reports saying that there are at least 4 types of menopause. There's spontaneous menopause, which happens when people are over 50 years, 50 and older. There's early menopause between the ages of 40 to 45 years, which is the absence of menses with no clinical reason. There's premature menopause, which occurs when somebody is younger than 40 years, which includes premature ovarian involution, which is a kind of waxing and waning of ovarian function. And then there's induced menopause that can come from chemotherapy, hysterectomy, which leads sometimes to ovarian dysfunction, oophorectomy, and in particular bilateral salpingo oophorectomy, BSO, or ovarian ablation via radiation. So we see here 4 very different types, 4 different ages, 4 different reasons for something that we capture in an umbrella term called menopause. So this might give us pause to begin to wonder whether we should be treating them all the same. Each one of these has distinct hormonal changes leading up to and after menses cessation, and each has unique health and cognitive consequences. So my perspective, and I probably don't need to tell this audience this, but that menopause in general and the different types of menopause specifically will have very different whole body effects. The ovaries secrete something called 17-beta estradiol that has an effect on every body system, the cardiovascular system, the musculoskeletal system, identity, blood pressure, then the kidney, the microbiome, the endocrine system independent of the ovaries, like stress and non-reproductive hormones, the immune system, and also the nervous system, brain and behavior. And this is kind of my perspective on the ovaries and what can happen during the many different types of menopause. When I think about the brain, I think about the ovarian-brain connection, which really starts with an organ that's not actually brain. It's the anterior pituitary. And the anterior pituitary, as you all know, secretes substances that affect the ovaries, that lead the ovaries to produce 17-beta estradiol and other ovarian substances that then affect the brain and can have feedback from the brain back to the ovaries via the anterior pituitary, which in fact is not a brain or neural structure. In particular, you can see all these regions in pink are regions of the brain that have 17-beta estradiol or estrogen receptors. But in fact, as a reviewer of an application I once wrote said to me in the review, there is no part of the brain that is unaffected by 17-beta estradiol, whether it has estradiol receptors or not. And in particular, for memory function, we're interested in the prefrontal cortex and the hippocampus, which are heavily studded with estrogen receptors and are very responsive to estrogens. In the rodent over the 4-day estrus cycle, spine density or synaptic connections change in the hippocampus with the waxing and waning of the production of estradiol. So the ovarian brain connection can modulate mood and cognition. Just to give you a sense of the contrast between spontaneous menopause and then surgical menopause, in spontaneous menopause, the work that's been done on depression and anxiety, in a review that looked at 12 prospective studies reporting depressive symptoms, major depressive disorder, or both over the menopause transition, found no compelling evidence for a universal increased risk of either depression or anxiety. Specific subgroups of patients, primarily defined by menopause-related risk factors like vasomotor symptoms, a long duration of the transition to menopause, or reproductive hormone dynamics, and some psychosocial risk factors, had a higher risk for depressive symptoms. But this wasn't true of the entire cohort or the entire set of cohorts in this review. And the increased risk of major depressive disorder over the menopause transition was predominantly in individuals with previous depressive disorder. And in this group, hormone therapy was thought to be effective in treating spontaneous menopausal depression. However, when we contrast that to depression and anxiety in surgical menopause or induced menopause, compared to referent women, within 3 months of BSO, there was twice the risk of depressive symptoms. The risk was elevated up to a year post BSO. The risk of anxiety symptoms were 3 times up to 3 months post BSO and seemed to plateau by 6 months. And hormone therapy did not modify this risk. When patients were looked at later in life, there was even later in life an increased risk of depressive symptoms in this group, diagnosed by physicians, and the increased risk of anxiety symptoms as well. In surgical menopause, estradiol up to age 50 did not modify the risk. So you can see that with depression and anxiety, there are very different, there are very apparent differences in depression and anxiety and their treatments. Now, we, many years ago now, reviewed the literature in a paper we called The Many Menopauses. And we were just curious to see how people doing research actually classified the different menopauses after the NAMS and Endocrine Society reports came out. And the take-home message of this slide is really that 38% of the studies on menopause in 2016 did not differentiate between any of the menopauses. They were simply recruiting women who said they were in menopause at the age of 65 or later into their studies. And they could have been including a whole host of different types of menopause, with some of potentially the earlier menopauses driving their results. Only 18% of the studies actually differentiated between the menopause types. And when we looked at how this was carried out in the observational studies as well as the RCTs, I think perhaps most interesting here is that, again, the RCTs were driven by studies that just included any menopausal type and didn't either limit the study to one type of menopause or didn't disaggregate their analysis by the different types of menopause. What we found was that this could have been the reason why so many of the studies on menopause and cognition have really kind of foggy results, because they're combining different menopause types. As you could see, if you did that for depression and anxiety, you might come up with very different results when you studied them later in life, studied people later in life. But when we looked at the papers that were specific on on menopause type and type of hormone therapy, we found that there were clear cognitive effects, including detrimental effects of CEE at the menopausal transition, comparing pre, peri, and post, at the menopausal transition. In a paper looking specifically at the menopausal transition and pre, peri, and post, they also found specific cognitive changes. So when taking the many menopauses into account, the differences in memory and cognitive outcomes are seen for each type of menopause. And I would say, looking at somebody in the clinic, one would really want to know what type of menopause they had, even if they were coming to you at the age of 65. Now, the good news is that current large cohort studies, like those coming out of the UK Biobank, looking at late life causes of dementia, are now including early menopause as one factor that might reduce lifetime exposure to estradiol, and finding that any reduction of lifetime exposure to estradiol increases dementia risk. So this is beginning to clarify the literature, and people are, at least in the basic science research and epidemiological research, beginning to take the different types of menopause into account. Now, in our own study of the UK Biobank, going directly to the question of spontaneous menopause, bilateral oophorectomy, or a combination of menopause types, when we compared risk and resilience factors for different menopause types against Alzheimer's disease. So our outcome was Alzheimer's disease. And then of the groups with Alzheimer's disease, we looked separately at bilateral oophorectomy, spontaneous menopause, and together. And quite remarkably, we found that HT ever was more beneficial to women in the bilateral oophorectomy group if they had their oophorectomy prior to the age of 50 than in either of the other groups. We also saw that ApoE4 was 4 times as risky. It gave women with bilateral oophorectomy 4 times the risk of late life Alzheimer's disease as women with spontaneous menopause or in the combined menopause types. Again, suggesting that we really ought to be thinking about this group of women with ovarian removal before the age of 50 quite separately from the group of spontaneously menopausal women. So we want to consider the type and age of that type to allow for more personalized medicine and treatment. Now, to go take a little deep dive into induced menopause, the repercussions are immediate. There's no such thing as a menopausal transition for somebody with surgical menopause. It's correlated with decreased verbal memory or memory for paragraphs and words if estradiol isn't replaced for 3 months post-oophorectomy. Exogenous estradiol improves verbal word recall after 2 months treatment post-oophorectomy. And if it's not treated with estradiol, it's correlated with decreased verbal memory out to 6 months. And this is actually an older study in women from Egypt. And I think it's important to point out here that they actually had very low education. The education level here was on the average 2 years. And I think what you see here is much more, much stronger than what you would see in the studies that I showed you of Canadian women, or that I will show you of other Canadian women later on in the talk. So that education component really makes a difference in the effects. But you can see out to 6 months, memory for numbers backwards, mental control, remembering stories or words, it all gets worse the longer you wait without replacing with estradiol. And the age of oophorectomy has been shown over and over now as being correlated with increased all causes of death and dementia risk. And Roca's first paper was 2007. It was preceded by papers by Parker, but Roca and others have gone on to show this over and over, including our own UK Biobank study. So the earlier induced menopause happens, the steeper the slope of cognitive decline. And you can see that here in this figure, that if you have induced menopause before the age of 38, the decline is hugely steep. Whereas if you have menopause at roughly the age of, greater than 49, or what they are here, natural menopause or spontaneous menopause, it's much less steep. And there's an increased burden in the global measures of AD pathology. So these investigators were able to actually look at the brains of women with ovarian removal prior to the age of 38, and they found a higher burden of plaques and tangles in the cortex of these women. If you image BSO, women with BSO, if they had it at the average age of 46, by the age of 63, it leads to smaller amygdalas, thinner parahippocampal and entorhinal cortex, and changes in entorhinal white matter fractional anisotropy. And all of this just goes to say that the hippocampus and the entorhinal cortical regions that are really important for the formation of new memories begin to suffer even at the relatively young age, for somebody like me anyway, of 63, if you had your ovaries removed at the average age of 46. Others have shown that if you have your ovaries removed before the average age of 46, you, compared to spontaneous menopause, you have worse sleep duration, worse sleep efficiency, and more insomnia. So sleep problems increase, and sleep itself is a risk factor for Alzheimer's disease. Now, our own studies in Canada, in Toronto here, and also we have a site in Linköping, Sweden, we ask what happens 1 to 13 years post-surgery, since nobody has been studying anything later than 6 months out to 13 years. Everything is either much later, starting at the age of roughly 65, or much earlier, only a couple of months after the surgery. So we decided to study women who carry the breast cancer mutation genes 1 and 2, who are recommended to have prophylaxis via bilateral salpingo oophorectomy. It's recommended before the age of 40. It has an 80% reduction in risk of dying from ovarian cancer, and a 56% reduction in dying from breast cancer. It's prophylaxis. Some of the women we study actually have already had cancer, but most of them have not, because they're doing this to maintain their health. They're doing it for reasons of preventing ovarian cancer. And as you are, I'm sure, better aware than I am, there are still a large number of oophorectomies done in the United States annually. Most of these are done for prophylaxis now. We're not as casual at removing the ovaries as perhaps we once were. And 50% are BSO. So in our study, we recruit women 1 to 10 years post-oophorectomy. We test each woman once a year for 3 years. This provides 1 to 13 years post-oophorectomy. And we study something called spatial working memory, sort of the ability to remember where you parked your car on a given day, and verbal episodic memory, the memory for stories and word lists. We do brain imaging. We have studied sleep. We measure estradiol, progesterone. We look at apolipoprotein E genotype, which is a risk factor for Alzheimer's disease. We're collecting cytokine and other markers. We do qualitative interviews. I noticed the CAT Center is really focusing on the patient experience. Well, you'll hear something about the patient experience in this talk. And we do body mapping storytelling, which I will explain to you later. Now, as you can imagine, since we're studying a population of women of whom there are not too many, we have a small but deeply phenotyped cohort. So our demographics, I think the main thing to show you is that the average age is around 44 years old of both our age-matched controls, the women who are taking BSO, taking hormone therapy but have BSO, and the women with BSO. And all the women in our study are taking some form of estradiol therapy. Some of them are taking unopposed, some of them are taking with progesterone, some of them are taking with progestogens. They all are highly educated. The age at BSO is roughly 40 years of age, and the average time since BSO is about 5 years. We have a group who has a history of chemotherapy, and as you can imagine, that group is larger in the women who are not taking hormone therapy because it's counterindicated in women who have already had some kind of cancer. And we use the CESTI to look at depression. We use the North American reading test to look at as a proxy of intelligence. And you could see none of the women are depressed and all of them are at higher of average intelligence. So we have a very highly educated group, which I think in some ways makes our findings a lot more, well, stunning, I would say. And as I said, none of them are depressed, but of course they vary in their levels of CESTI scores. So first we want to show that when they have BSO, it reduces their 17-beta estradiol and progesterone levels. And that's what these two graphs really show, that measuring estradiol glucuronidase and progesterone that are urinary metabolites, and we find that the women with BSO have significantly lower estradiol, as do the women with BSO have progesterone, but that the women taking E2 have roughly the same levels as our age-matched controls. The women with progesterone is all over the map, and I think that's because the progesterone therapy really varies so drastically in these women. When we look at paragraph recall by a test called logical memory, we find that for the immediate, asking them to recall it immediately after reading or asking them to recall it after a delay, that there's a significant difference between both the women taking hormone estradiol and the women who are not taking any hormone replacement and the age-matched controls. So this goes down significantly, and estradiol therapy does not maintain this ability to remember paragraphs. And remember, these women are on the average of 45 years of age. When we ask them to remember numbers backwards, we see that the women with BSO are doing worse than the age-matched controls, but the women with BSO taking estradiol therapy are doing as well as the age-matched controls. So I would say they have what I would call an intermediate phenotype. This is also true for another working memory task called spatial working memory. It's exactly the same. In this case, we measure errors. So the number of errors go up. And so the women with who are not taking estradiol are doing worse on both immediate and delayed errors. But estradiol therapy seems to maintain the ability to do this. And again, these are women who are roughly the age of 42 years. When we look at the hippocampus and we do scanning for the hippocampus and we look at a specific region of the hippocampus in the posterior hippocampus called the dentate CA2-3 region, we find that that region in particular there is a significant difference between the age-matched controls and the women who are not taking hormone therapy. That's the orange bar here. There is, in fact, no difference in the size of this region in our spontaneously menopausal women. So I think this is an important indication that there's a difference in brain structure between the women who are on the average of 45 years old, 42 to 45, who've had their ovaries removed at the average age of 38, and the women who are in spontaneous menopause, and also the women who are taking estradiol therapy. Estradiol therapy helps to maintain the structure of this critical brain region for memory. Now, if we ask the women to do paired associate memory task, like matching a name to a face, so they're shown the faces, and then they're shown the names and the faces, and then they're just shown the faces, and then they're shown the names, and they're supposed to match the names to the faces. That's called paired associate memory. On novel repeat pairs encoding, we actually do not see a difference between the women with BSO not taking hormone replacement and the women with BSO taking hormone replacement and in the age-matched controls. Here, our big difference is in the spontaneously menopausal women. And I think that's interesting. This test is used a lot in older women. It's called the Sperling task and has been designed by Riza Sperling. And it shows this difference between age-matched controls and spontaneously menopausal women, showing that at least for the behavioral component of this task, it's really important that age be involved. It doesn't show up in younger women. Now, if we actually look in the brain, however, what we see is that the women with BSO look exactly like the women in spontaneous menopause. And they're both significantly, their activation of this brain region is significantly different from the women taking estradiol therapy. So estradiol therapy actually increases function in this region, whereas BSO without any estradiol therapy, the women have much lower activation when they're performing this paired associates task. And here at the age of 45, they look just like women in spontaneous menopause. What about sleep? Well, it turns out that the women who've had their ovaries removed at the average age of 38 have disturbed sleep. Here we see, when we look at sleep latency, which is the amount of time you spend in bed before you go into the first stage of sleep. So sleep has a number of different stages. And over the course of the night, you cycle through these stages. And the first stage is the stage that determines sleep latency. So the women, all the women who have a longer sleep latency, all of them in our study, and that's why you see all these different colors here because they're all included. Those who have a longer sleep latency have worse paragraph recall. They're actually making more mistakes on remembering. Now, in this, where we look at the anterolateral entorhinal cortex, we see everybody with poor sleep latency taking longer to go into stage 1 sleep. They have reduced anterolateral entorhinal cortical volume. So that means sleep latency is important for maintaining the structure of this part of the hippocampus, part of the medial temporal lobe that's important for memory. And again, if we look at sleep efficiency, which is how long you're in bed over the time that you're in bed, that you're actually asleep, you see that as you spend more time in bed and not asleep, you also, the better your sleep efficiency, the larger your anterior entorhinal cortex. So sleep is incredibly important for the maintenance of these hippocampal regions. Now, what does this mean for women with BSO? When we look at women with BSO and we give them take-home polysomnography, that is, they learn how to wire themselves up to stuff that measures the different stages of sleep, we see that the women with BSO have poorer sleep efficiency. They have poorer, longer sleep latency than the women with BSO taking estradiol therapy and also the age-matched controls. They look a lot like the women who are in spontaneous menopause. And again, these are younger women. So when we look at the odds of subjective cognitive decline in our cohort, we find that ET is a resilience factor. So what is subjective cognitive decline? You probably all know, but because I can't see your faces, I'll just say that, Alzheimer's disease is roughly now being studied in 3 different stages, marking earlier and earlier stages, because now we know it's not getting Alzheimer's disease isn't like getting a cold. It doesn't happen all of a sudden. It happens gradually over the years. And one of the earliest stages is something called subjective cognitive decline, where individuals go to their usually primary care physician and say, my memory isn't as good as it used to be. When they're given the standard memory tests in the clinic, like the MOCA or the mini mental exam, they don't show any objective deficits on those exams, but they do go away still feeling that they have memory problems. And I would say that's roughly where the women in our cohort are. In fact, they probably joined our cohort because they're concerned about their memories. And we find that after looking at the demographics, where we include the women who are young women who have the BRCA mutation but haven't had their ovaries removed, the age-matched controls, and the women who have had their ovaries removed, we see that BSO is actually the biggest risk factor in this group for poor performance on logical memory or a story, memory for a story, and also on spatial memory, working memory, memory for where you parked your car on a given day, or lists of numbers. We find that BSO is the biggest risk factor, and estradiol therapy is the biggest resilience factor, or the factor that helps them the most. Now, when we take this whole cohort and we do a multiple factorial analysis to look at the correlations among the multiple variables that we understand as comprising risk and resilience, like BSO, stress, depression, high education, and correlate that with neuropsychological performance, we find that there are 2 dimensions that come out. The correlation circle shows all the dimensions, including factors that were not significant. But when we look at the contributions to dimension 1 and dimension 2, we see that dimension 1 identified a general pattern that shows that BSO is the largest variable. It contributed to the highest risk, and it was negatively correlated with logical memory. And this was followed actually by carrying the BRCA1 mutation. But in this dimension, it might be mitigated by verbal IQ as indexed by the NART and education. In dimension 2, we see dimension 2 is specifically identifying a pattern for women with BSO alone, and showed that the women with BSO who had the BRCA mutation, the BRCA1 mutation, and had used estradiol therapy, had lower stress by the PSS and also lower numbers on the CESD, or the Centers for Disease Control Depression Index. So in this group of women with BSO, BRCA1 is a high risk, highest risk, and taking estradiol therapy mitigates the risk of depression and or poor mood, I would say more precisely, and stress. Now, what about sexual function? So sexual function, I mean, this is, we haven't done the first study here, where this is not the first study on women with BSO and even the BRCA mutation and sexual function, but we are the first study, which now it's under review, to look at the different components of the sexual function index, and also to look at, to compare them with spontaneous menopause. And here we see that the total FSFI score is lowest for women with BSO, no estradiol therapy, lower than, in fact, for women in spontaneous menopause, and also significantly lower than their age-matched controls. And it's actually, I just show two other subsections of the FSFI. So on desire, they're spontaneously lower than the women, than the AMCs, the age-matched controls, if they don't have estradiol replacement. And for pain, they're significantly lower than the women taking estradiol therapy, than the spontaneously menopausal women, and also the age-matched controls. It's also true that they were lower for arousal, lubrication, orgasm, and satisfaction. But I didn't have room on this slide for every single plot, but you can see it's pretty severe for them. And again, they are on average, in this case, about 42 years old. Now, when we ask them in qualitative interviews, are you having any problems remembering things or concentrating? We hear, I started noticing memory problems. The issue is primarily the speed of recall. I can eventually remember the name that I'm searching for. It just seems to take far more time. I notice this lag with names or people, as well as names of books or places. It's as if a blank space opens up in my mind, and I'm trying to fill it with the information that I know is filed somewhere in my brain. This problem is worse if I'm sleep deprived. And another participant says, post-BSO, I started noticing I no longer remembered conversations, people's names. It took a lot of effort to recall where I'd placed things. I mean, these are logical memory and spatial working memory that we measure. If they're not in their normal spot, lack of focus, concentration, particularly at work, it takes me a long time to get into productive pattern. I need no distractions for long periods of time to focus. And again, I want to say to you, imagine the plight of these women. They're still working. They have families. They're probably taking care of aging relatives. These are, although they're not performing, they're significantly worse than age-matched controls, they are performing in the range of normal. These changes have an effect on their quality of life. And when we ask them, are you having any problems remembering things or concentrating, they didn't hesitate to tell us about the problems they have being told that they're in menopause. So, a quote, in some ways, I look forward to being more middle-aged and into the point where women will generally be without their hormones, because then I won't feel like such an outlier. Do you know what I mean? Like, I'll feel less pressured to feel more normal, because it'll be like, okay, at this point in my life, I would probably be low on estrogen anyways. I'd be going through menopause. You know, I won't be such an outlier. They're told they're going to be in menopause. They're not told about the depth of the symptoms they will experience, both cognitively as well as sexually. Um, and they're struggling with this idea that they're supposed to be like somebody who's, you know, 55, 60 years of age, but they're young women still. And it scrambles their identity. Now, when we do something called body mapping storytelling, which is essentially having women lie down on a large sheet of paper, tracing the outline of their bodies, and asking them to put on their bodies using art supplies, um, anywhere it fits best on their bodies, uh, where their memories are located. And then when they're done, we ask them to put a personal slogan since BSO, a message to their physicians, and a message to other women considering BSO. We get really extraordinary visual depictions of their memories, their struggles, and what they're trying to do to maintain all of this. And then we ask them to actually tell their story while they look at the body map. This is an example of one body map. And I'm going to show you 6 others. I won't go into a lot of detail, but this is full size. And you see all of them contain something about nature. They show symbols and signs above their brains indicating I think they think their memory is still in their brains, but they're having problems with it. Things are usually floating around outside their brains, and often there's a fire or something going on underneath that might indicate some kind of problems controlling their bodies or their brains. When we looked at these when we looked at their stories of embodied memory, we found a number of different themes, but the ones I'm going to just show you, elaborate on today with the pictures is chaos around the head and memory tools. So again, chaos around the head is often shown by spirals coming out of their heads, problems with remembering things. This one doesn't actually show memory tools, but like the one that showed a fire underneath, this one shows lightning, as if they've been struck by lightning by the BSO. They try to show they're grounded by the earth underneath their feet. And this woman carries the memory of her mother in her heart. Her mother died of ovarian cancer. Again, the same thing, the spirals around the head, trying to be in nature to maintain their poise and equilibrium, nature underfoot as well with grass, lots and lots of lists. This woman had what I would call memory hygiene. She kept diaries of everything. And that helped her memory for stories. And this woman shows this, almost like an electrocuted hair phenomenon of not being able to remember anything, the sort of disconnection of her head from her body, and all these things floating outside her head that seem to be given off by what's coming out of her head. The memory tools, we see again, good eating. I think these are raspberries here. Some pictures show barbells. Here's her notebook, which this participant was actually kind enough to give us. And also the picture of her ovaries with the eggs coming out. This woman with her memory tools, her brain's been zapped, but her memory tools include good eating, being outside in nature, doing activities that increase her sense of well-being. And this woman, a fan to ease the hot flashes. She says that her brain is a lot like a tree. Sometimes there are lots of leaves on it, and sometimes there are fewer leaves on it. She uses barbells and exercise. A pencil denotes all the notes that she takes, and she likes to play memory games. Cards indicate that. So there's a lot of attempts to maintain their memory as well as admission of the memory problems. So in conclusion, there are many menopauses. It's important to acknowledge the individual differences. All menopauses are not created equal. To understand the cognitive complaints of patients, we need to specify the memory type, the menopause type. We need to look at BSO prior to spontaneous menopause as being the riskiest with respect to late life AD. Estradiol levels drop precipitously. There is no transition, and there are decrements on tasks associated with early signs of Alzheimer's disease. Estradiol therapy ameliorates many of these early changes and contributes to resilience, but it is not a silver bullet. Participants are told they're in menopause, but this is not spontaneous menopause for them, not in terms of the symptoms and not in terms of the Alzheimer's disease risk. The different menopauses have different cognitive, brain, and experiential effects. And with that, I'd like to thank my students and collaborators, all my funders, and you. Thank you very much.
Wow. I mean, that was just such an outstanding talk, Dr. Einstein. Oh my goodness. I actually have palpitations a little bit listening to some of what you were saying, because it really causes you a lot of anxiety when you think about this. There's a lot to ask you about and only a few minutes to ask you. So, for me, as a breast imager, so involved in trying to identify women who are at hereditary risk. We're building a hereditary risk program right now.
Oh, great.
And we're seeing a lot of these BRCA patients. These are young women. We feel like we're doing good for them, right? That we're reducing their risk of dying from ovarian cancer and from breast cancer. But what advice would you give us when we're counseling these patients, in terms of what are the other things that they should be thinking about before subjecting themselves to this kind of surgery?
Yeah, I mean, you're so right to bring this up, and I think this is the tragic between a rock and a hard place for them. Life has to be supported. Life is incredibly important, and this is the most successful life-sustaining. The BSO is the most successful life-sustaining surgery pre-treatment for these women, and I don't think they would make a different decision. We see this over and over. You see it in the quality of life literature. We're hearing it from our participants. They wouldn't make a different decision. They would like to be better informed. And we're currently, slowly but surely, working actually on a booklet, we're hoping. Well, these are small studies, so they're not technically considered evidence, in the medical literature, but I think it's still worth the patients knowing these things. They can't make book on it. It may not happen to them, but it happens to a lot of women. So I think it's definitely worth discussing with them the possibilities of sexual problems, the possibilities of memory problems.
Yeah. I mean,
with the caveat that aside from the large epidemiological studies of late life, we don't have good epidemiology of early life, but it looks like it starts early and it continues.
At the same time as we're building a hereditary risk program at CATS, we're also building a menopause program. We actually have more NAMS certified menopause practitioners now at Northwell than anywhere in the country. I think we're over to 40. The CATS Institute has supported that effort to get our clinicians certified in menopause care. And so this is so interesting to so many of us on this call. I'm texting like crazy on the side with Dr. Stephanie McNally, who wasn't able to attend, but who's running our menopause collaborative. And some of the things that she was saying is, the evidence that you presented is so mixed around hormone therapy. And is that just because we're not always talking about the same thing when we talk about hormone therapy? And, some of the things, that she's been mentioning to me on the side that the research needs to be done are around, what exactly was the dosing? What was the modality that was being used? Was it oral? Was it patch? What,
Yeah.
was progesterone included or not included?
Yeah.
And she specifically wanted to ask me what your thoughts were on oral contraceptives for hormone replacement, because she was saying, and this is not my area of expertise, that it may be more bioavailable. Is that something that you have all investigated at all? Or is there a cohort of your patients that have used birth control pills as their hormone replacement method?
Yeah, there might be a few patients who've used birth control pills, but most of our patients have been given some form of 17 beta estradiol with a progesterone or progestogen. Some of them are patch, some of them are gel. They have all kinds of things. And the best we could do was say they're all taking estradiol, which is better than a lot of studies. But as you say, there's a huge amount of variation there.
And do you think that explains some of the mixed results that you're getting in terms of, I mean, in some of the ways that you evaluated, cognition, memory, behavioral things, there seemed, in some of the studies, there seemed to be better response to the hormone therapy than in others. And do you just think that's because of the heterogeneity of the hormone replacement that we're talking about here?
It could well be due to that, but I also think there's a lot of individual variation. I mean, even if you look at a quote normal menstrual cycle, you look at 4 normal menstrual cycles, you see an enormous amount of variation in hormone levels, days of the cycle. So they're going into this with a lot of variation, and I think they're going to have really variable responses. And so what we're looking at, actually, I mean, I know the main physician that most of these women see, and it's not a one size fits all. She's experimenting all the time. They don't usually end up on the hormone therapy they started with. They're going back because it doesn't work, and then they try something else. So it's a
And what
very
kinds of
complicated
physicians are
process.
managing that? Like, do you feel like in our hereditary surgery program that we should be matching all of these patients with a specific clinician that's going to be managing this? Should it be a menopause certified clinician? Like in the dream world, how would we make sure that we're getting people onto the right kind of hormone therapy after this surgery?
Yeah, I mean, I think somebody, it could be a menopause physician. I'm not an MD, so I don't know the details of these specialties anymore.
Yeah,
But it could be a menopause physician. It could be an endocrinologist,
yeah.
because they may want to be on something that's not estradiol, that's not testosterone, that's not an androgen rich progesterone. I think it's going to be complicated, and I think you would be doing them a huge favor to actually make it uh you know seriously multidisciplinary. um
And I think potentially a differentiator for anybody trying to have this kind of surgical program to be thinking proactively about this kind of stuff, both
yeah.
pre-surgically and post-surgically. Unfortunately, I could talk to you about this for like
Well,
hours,
I
but
would love to talk to you offline about it,
and I
because
want you to meet Dr. Stephanie McNally and the people and
okay.
Dr. Tana and the people that are running our hereditary risk program, because I think this isn't something that we've been talking about enough, and it's something that we should be talking about more. Your talk was fascinating. I said it gave me palpitations at times just thinking about all the things that we're not thinking about for these young
Yeah.
women. And I hope that we can continue the conversation with you. Unfortunately, for anybody that put questions into the chat, I apologize if I didn't get to your
My fault.
question.
I'm sorry. I had so
No,
much I wanted to say.
your talk was wonderful.
Okay.
Thank you so much for being here. I'm
You're
sure
welcome.
I speak for everybody that was on this call to say that this was really an eye-opening talk, and one that I think is going to impact the way we think about clinical care.
Thank
So
you.
thank you so much.
You're
And
very
thank
welcome.
you to everybody who attended this talk today on behalf of the Katz Institute and Dr. Rosen. We look forward to seeing you at the next Katz Institute for Grand Rounds.
Yeah.
Take care, everybody.
Thank you so much.
Take care.
Bye.